is a lot of focus on cost effectiveness in all aspects of healthcare because of the huge pressures on healthcare budgets, especially these days. And when we look at rare and expensive diseases like hemophilia, we have been used to treating episodically, which consumes a certain amount of factor. Using prophylaxis, we consume much more factor. So there is the possibility that there will be increased costs. And hence we are interested in seeing if these result in more effectiveness. Well, historically, the key outcome has been that although there is no doubt that prophylaxis is effective, its costs outweigh the effectiveness. So we have what we call in pharmacoeconomics negative cost effectiveness ratios, which might imply that cost effectiveness of prophylaxis is less than that of on-demand therapy. Such studies on cost effectiveness on prophylaxis up till now have continued to confirm that while there is no doubt that the effectiveness is large, by continuing prophylaxis, especially after the childhood years, we incur costs at a higher rate, which make the cost effectiveness less favorable, especially to authorities who have to continue to pay and reimburse the treatments. Well, recently we have been interested in looking again at estimating the cost of a quality-adjusted life year in prophylaxis against on-demand therapy, but this time from the point of view of the whole life of people with hemophilia. So we estimated the cost per quality-adjusted life year from the very earliest months of life to an average life cycle, which in the developed world, I think we can say that for males it's about 80 years. And we estimated the cost utility of prophylaxis against on-demand therapy during this whole period of time. We constructed, for estimating the cost utility analysis, a model based upon a commercial software package which utilizes what's called a Markov analysis, which means that we look at different health states throughout a very long life cycle, which in this instance is about 80 years, looking at all the complications which can occur for a person with hemophilia during this time, including the incidence of inhibitors, the possibility of requiring joint surgery and other morbidities like intracranial hemorrhage for both prophylaxis and on-demand therapy. For this model, we used data which is available in the public domain, mostly for the peer-reviewed literature and other data provided by funders for costs and other aspects like that. In this model, we have included emerging and rapidly confirmed data on some key aspects of hemophilia care, which we are now aware are very important, particularly the problem of increasing hemorrhage as people grow older, like intracranial hemorrhage, and the very important probability that prophylaxis decreases the incidence of inhibitors if it is initiated very early in the first months of life. This is utilizing data amongst other countries generated here in the Netherlands using the so-called Rodin study, which has been published in many journals, and also the data from Germany in the Bremen clinic of Professor Auerswald, which indicates that when the children are exposed to factor VIII at a very early age, there is a tolerization phenomenon which decreases the incidence of inhibitors. This, of course, makes prophylaxis much more cost-effective, because inhibitors are dreaded clinically and very expensive in terms of reimbursement of the concentrates. It is very important in using pharmacokinetic dosage to realize that different dosage regimens can give us the need for different amounts of concentrate. So when effectively we dose more frequently, we are able, because of the pharmacokinetic properties and the individual patients, to give effectively less factor VIII. This obviously decreases the costs. At the same time, by exposing the patients at earlier years, we are decreasing the probability that they will develop inhibitors and have to be treated for this extremely expensive and difficult complication. This, in our model, results in the cost of a quality-adjusted life year being much less for prophylaxis than for on-demand therapy. And I want to emphasize that this model needs to be applied separately to separate countries. In our publication so far, we have applied it to 3 countries and we have obtained this result, and we look forward to perhaps even other people attempting to try the model out in their own particular national environments. The model was applied to 3 individual case studies: the United Kingdom, the United States, and Sweden. Now, these are quite different healthcare systems, especially in the United States, where it is basically a market-driven system compared to the social market economies of the United Kingdom and Sweden, where the government is the main healthcare reimburser and provider. But it is interesting that even in such diverse systems, we get reasonably similar outcomes in the sense that prophylaxis is more cost-effective than on-demand therapy. The extent to which this happens differs between different countries, mostly on the basis of the particular cost of the product, factor VIII concentrate, in the individual environments. And I emphasize, we have applied this from the earliest months of life until the end of life. So we can see that maintaining prophylaxis over the whole of life is important therapeutically and saves medical costs. And this is the important feature, that it's not a case of how much the product costs anymore. It's a case of how much medical costs, involving the cost of surgery, involving the cost of hospitalization from dangerous bleeding, and involving the cost of inhibitors. And when one considers all of this, especially in the current financial climate of pressure on the healthcare system, prophylaxis turns out to be a cost-effective measure wherever we study it. The results show that in, as I said, all of the 3 national contexts, we got cost-effectiveness. In the United Kingdom, where the price of factor VIII happens to be lower than in most other countries, the situation was what is called pharmacoeconomically one of dominance of cost of prophylaxis versus on-demand. That means prophylaxis was both more effective and also cheaper. In the other 2 countries, the United States and Sweden, we got a positive cost-effectiveness ratio, which means that while cost-effectiveness was more expensive, the costs were higher, but the effectiveness was higher still. So that we got a ratio which is positive. Now, reimbursing agencies in these countries have certain criteria by which they approve the funding, the reimbursement of interventions. The ratios we have generated in our model lie within the range which are in these countries invariably supported by reimbursement. Therefore, we feel that cost-effectiveness of prophylaxis is now proven, and there should be no more impediments from the aspect of reimbursement by authorities. We hope this will be the case because there's no doubt, nobody argues, prophylaxis is effective. Nobody argues that adult patients should continue to be treated prophylactically. The doubt has been on the cost effectiveness. We now hope to have dispelled some of that doubt. We are forced to conclude that we have, as I said, proven that cost effectiveness is the case with prophylaxis against on-demand therapy. And we are now living in an era of hemophilia where we have hypothetically no restrictions on supply. The products are safe from all the agents of infectious disease which were a problem 20 or 30 years ago. So the only impediment is the question of funding the treatments. We feel that we have shown that healthcare systems should fund these treatments because in the end they are going to cost less money, because the patients are going to live longer, more productive, and less health intensively costing lives. So we think that this is the key outcome, and we think that the whole discussion on whether hemophilia is cost effective or not to treat hemophilia is something which should not be the focus anymore. It should be what should be the focus is the splendid discoveries shown at this conference about new products and better forms of therapy. Of course, all models in pharmacoeconomic analysis depend on certain assumptions, and our key assumptions regarding pharmacokinetic dosage and the lower incidence of inhibitors are the subject of yet more investigations, including increased clinical trials, and we hope to see that the data coming out of these types of investigations will further confirm our model and its effectiveness in relation to all environments and not just the 3 which we have studied so far.